Well, good afternoon and welcome. It's very good to be here today to welcome you to the next in the series of the Royal College of Pathologists webinars around guideline implementation. I'm Peter Johnston. I'm the Vice President for Professionalism at the Royal College of Pathologists, and I'm very pleased this afternoon to be hosting this webinar, which is looking at the dataset for histopathological reporting of soft tissue sarcomas. The point of this, the aim is to try to clarify important matters, highlight potential difficulties, and provide you with some useful tips and practical value in reporting these tumours. Again, it's a great pleasure to welcome Professor Cyril Fisher and Dr. Khin Thway, who are going to deliver this presentation and answer questions. Before we start the presentation, can I just remind you that the presentation itself will last 15 minutes approximately, and there will follow with about 20 minutes of questions and answers. If you want to ask a question, and I would warmly encourage you to do so, please do this on the question and answer function that appears on your screen, and we will convey those questions to the experts who will then answer them over the system. So without further ado, I would very gratefully welcome Cyril to provide his presentation. Cyril, thank you very much.
Thank you, Peter, and good afternoon, everyone. So I'm going to talk about the new edition this year of our data set for histopathological reporting of soft tissue sarcomas, just to highlight some of the changes and a couple of other points. This is quite a long-lived data set. The first edition was 2009, so it's 12 or 13 years. I did the first 5. And of course, the subject becomes more and more complex. And I'm very glad this year to have had the help of my former colleague, Khin, Thway. So sarcomas are rare. And it's usually said they comprise about 1% of all cancers. Just by way of a little bit of background, this is something like 50 per million as an incidence, which means in the UK, there might be 3,500 cases a year. That's probably an underestimate, but it's a usual figure. Interestingly, the college informed me there are just over 2,000 histopathology members in the UK, which could mean on average that each pathologist only sees 1 or 2 sarcomas a year. I'm sure they all see more, but the point to make is they are rare. And yet they arise virtually anywhere, any part of the body, skin, subcutaneous, deep soft tissue, and of course in non-soft tissue sites, including all the organs. And so we get cases from any part of the body, and this adds to the complexity. But anybody can see them in general surgical pathology practice. A lump is a lump, and you don't know what it is until you get the biopsy. But sarcomas are not one tumor. There are over 100 subtypes, many of which have subtypes with myxoid, inflammatory, sclerosing changes. It's a complex and difficult area requiring quite a bit of experience. And of course, they can mimic carcinomas, melanomas, or lymphomas and can be misdiagnosed as such. It's not surprising, therefore, that there are discrepancies between the diagnosis made in a non-specialist center with the diagnosis on referral to the specialist sarcoma center. But what is interesting is the figure for discrepancy in diagnosis, and this includes serious discrepancies and minor discrepancies, has remained almost constant for the last 30 or 40 years, notwithstanding the improvement in investigatory methods, immunohistochemistry and molecular diagnosis, improved training, and wider knowledge of the subject. So it's quite interesting to see that this still remains a difficult problem, not only for diagnosis, but also for grading of sarcomas where this has been looked at. So based on this, NICE has issued guidelines for diagnosis and reporting, which indicate that all soft tissue sarcomas should be either first reported or reviewed by a specialist sarcoma pathologist. What is that? This is a pathologist who regularly reports soft tissue tumors as a significant component of the workload. Significant is not defined, by the way, but it is usually taken to mean 100 sarcomas a year. This pathologist must actually, rather than should, participate in EQA. The national EQA is available, and be a member of a sarcoma MDT. There are also centers with smaller numbers of cases where the pathologist has an interest, and this can have links to the main sarcoma MDT and specialist centers. And it's interesting to note, I think the discrepancy percentage is less for people who have a special interest and focus on the topic, as you might expect. But you will see them in general hospitals. And not only that, if the biopsy is reported or validated at a specialist center, the resection may be carried out locally. So it behoves us all to be aware of the data set, trainee and general pathologists. And of course, as the college always says, these data are of great value for other purposes, such as cancer registers and standardized cancer reporting. So what is new in this latest version? Well, a lot of it has not changed. Sarcomas are sarcomas, but there has been a new WHO classification published since the last version of the data set. So the content has been updated to include these recommendations. This mostly affects the appendices of the data set A, C, and D. The specification or instructions, if you will, for the mitotic index have been changed to reflect the fact that we use area rather than high power fields. And of course, because a rapidly expanding subject of molecular pathology of sarcomas, the advice on molecular genetic and cytogenetic testing has been updated. And of course, the references. There's explosive amount of publication in this field on a daily basis, mostly with molecular data. So the three appendices that are particularly affected in the revision of the data set are the histological types of sarcoma, the grading system to a small extent, and of course, the molecular changes. So if we can look at these now. So the WHO published a new consensus classification, the 5th edition in 2020. This is built on the previous consensi 2002, 2013, which postulated this classification, which is that sarcomas, soft tissue tumors, are classified by lineage. That's to say the type of tissue they're trying to form. We do not talk about cell of origin because it's usually unknown, especially as it's the genetic changes that drive the tumor. So these are the categories in alphabetical order. In parallel, there's another classification which is behavioral. So we have benign soft tissue tumors and malignant, which is sarcoma. But in addition, there's an intermediate category, itself divided into two: locally aggressive non-metastasizing neoplasms. The type example is fibromatosis, or rarely metastasizing tumors, rarely with an arbitrary cutoff of less than 2% of examples metastasizing. So this leads to changes in Appendix A of the data set, and I've set out the histological types, and we have added, so this is just sarcoma, of course, intermediate and frankly malignant tumors. We're not dealing with benign ones in the data set. So with the SNOMED code and the SNOMED CT code, and they're listed there as well as the terminology, which varies a little bit depending which SNOMED you're using. And this now spreads onto 2 slides, but you'll notice also that if we go to tumors of uncertain differentiation, this remains really quite a very large category. And that means we don't know what these tumors are trying to form, which type of tissue, but we do know quite a bit about their molecular underpinning. And you'll notice many of these have got the old-fashioned descriptive names: synovial sarcoma, epithelioid sarcoma, alveolar soft part, all now known to be translocation associated, but the names are quite hard to change and probably inappropriate to do so. Now, the changes in Appendix C, there's a tiny bit of change in the grading system, which is for the mitotic index. So we have moved from high power fields to area. Fortunately, most high power fields, 10 high power fields generally means 2 square millimeters. And so this is how we express it. And I report with both. I say per 10 high power fields equals 2 square millimeters. You need to assess this on your own microscope, but in general, it's easy to do. And there is a table in the WHO book to help you to do that. Just a word about grading differentiation score. This doesn't mean well, moderately, and poorly differentiated. Score 1 is where the tumor is similar to normal tissue, a very small number of tumors. Grade score 2 is where the sarcoma is defined subtype with a name, and score 3 is uncertain type. They do not correspond, these scores, to well, moderately, and poorly differentiated. Unfortunately, the grading system given in the WHO book does use the terms well differentiated and poorly differentiated, but it's fairly easy to apply the differentiation score based on this, because well and poorly are quite wide apart in most tumors. With regard to grading, there's been a slight change now, which, as I mentioned, is to use area rather than high power fields, based on the concept that the high power field varies from microscope to microscope. In practice, most do equate to a field diameter of about 0.5 millimeters, and so 10 high power fields equals 2 millimeters squared. And this is something you need to assess on your own microscope. So we express the mitotic index now per 10 high power fields or equivalent area. And remember, this is a grading criterion, so we have to count them. For some tumors, we count 50 high power fields. These smooth muscle tumors, glomus tumors, OFMT, and GIST. And this is a sort of benign malignant or behavior predictive activity. It's not a benign malignant, really, because there's a continuous spectrum here. So in Appendix D, we modified the translocations and other genetic changes in sarcomas. This is an exploded field, and every iteration of the data set has many more columns and many more listings under each tumor type as the changes are discovered and described. So it's non-exhaustive, it's evolving, and it's even out of date as we speak, because something new is published every single day. You'll notice a couple of things. So this is the first, it's alphabetical. Here's the first page, and here's the second page. And you'll notice a number of things. That is, the same tumor type can have lots of different molecular abnormalities, which makes life a little bit more different. But also, the same abnormality can be found in other tumor types. So we have to be aware of quite a lot of these things and to understand the limitations of each discovery as we make it. And you'll notice now, just to remind you, although it's becoming fairly commonplace, we don't use a dash between the two components of a fusion, we use a double colon. Just to remind you, benign soft tissue tumors also have translocations and other genetic abnormalities as well. And so really the whole soft tissue scene is basically underpinned by knowledge now of the molecular changes. This is not part of our data set, but it's just for your information. What we've added something here in the 1.2.2, the roles of cytogenetics and molecular genetics. For pediatric tumors, genetic data can be regarded as essential. So it's more or less mandatory to do molecular analyses, that's to say FISH, perhaps PCR, and now NGS on pediatric tumors, particularly small round cell tumors, and the clinicians require it. For spindle cell sarcomas, it's not so mandatory because we don't have the treatment options, but we know quite a bit more now about molecular underpinning. And so we are able to identify subtypes of subtypes. And so it's becoming quite widespread now to do NGS on spindle cell sarcomas and others. And this may or may not translate later into therapeutic options. So we will do FISH, we will do RT-PCR, and increasingly we'll do RNA-based NGS. And we can do all these on fixed tissue. However, some approaches, including what's starting to be introduced, which is whole genome sequencing, may require unfixed or fresh frozen material. So it's fairly easy to get another core if required for this purpose. Now, this is not new in the data set, but this is something that's been in each data set and yet often raises questions of how to deal with the tissue. And I just would like to reiterate it. The first is not to put all the cores in a core biopsy in the same cassette. Because if you do, you cut through them all simultaneously and you simply do not maximize the use of the material for investigation. So we should separate them into at least 2 cassettes and preferably more. If you have 6 cores, use 6 cassettes. The lab may grumble, but it will be invaluable in maximizing the use of material for increasing numbers of investigations that are required, including, of course, molecular investigations. So that's just to make a plea in a way for that, so they don't all cut through at once. Should you do levels? In general, you don't need levels on a core biopsy because the needle usually goes right in the middle of the tumor, so it's considered to be representative. But if you feel there's a bit of tumor, or you see a bit of tumor just on one edge, you may want to cut in to try and get more of that. In reality, you usually lose it, but at least you could try. And of course, that's the advantage of having lots of different cores on different slides. The other point is how many margins to take. And you take the nearest dissection margin and the deep margin. It may be the same thing. 3 millimeters, 3 centimeters, 30 millimeters away, you don't need to worry, it's too far, except for some tumors that can spread, like low-grade mixed fibrosarcoma or be multicentric epithelioid sarcoma, which can infiltrate. And then you may have to take more margins. I tend not to take 6 or 8, although the surgeons tend to request it, like, for example, a breast excision. And they send it with sutures and a bit of ink. And but I think in reality, you only need the nearest margin and maybe the deep margin, with the exceptions I've mentioned. Obviously, small lesions you will process in the entirety, and you can put ink on. I don't put ink around a large specimen. I dab the area where I'm going to take the block. So really, that's all I wanted to say by way of sort of introduction or changes in this data set. And of course, I'm now happy to answer any questions. Thank you.
Cyril, thank you very much. That was really interesting. There's a number of really pressing questions come up out of this. And while people are getting their questions together, I wonder if I could start off by asking you something. It's about the molecular pathology, really. And it's interesting when you look at the data that you presented. As you said, there are markers which appear in a variety of tumors. Different tumors have sometimes the same marker. At the same time, there's a relationship between the benign and the malignant tumors. So are the molecular markers any use in predicting whether something that would be low grade perhaps is malignant or benign? How is there utility in the molecular pathology for helping us sort that out?
That's a really good question. I think yes, to a limited extent. In a way, I think most fusions and most markers are really diagnostic rather than prognostic, shall we say. And I don't know, Khin may want to have a comment on this, because this is something she's thought about as well. And I think there are 1 or 2 areas, and I'm just struggling to think, where fusions or single mutations are prognostic. And I think possibly in GI stromal tumors, the exact changes may have some prognostic significance. Largely, though, most of these changes are diagnostic rather than therapeutic. Khin, do you want to add anything?
Yeah, thanks, Cyril. So yeah, interesting question from Peter. I agree with Cyril in that most of these changes are helpful to prove a diagnosis. Now that we've got NGS in lots of centers, I think we're lucky in that, for example, there can be very cellular fibrocystomas that can be hard, particularly on biopsy, to distinguish from DFSP. And now we have the means to prove that it's DFSP or exclude DFSP, or even sometimes we get PRKC, PRKB fusions. So in those areas, it is actually helpful. Generally, I think the molecular is helpful, as Cyril says, for confirming something.
I might add that sometimes gives therapeutic options in that some fusions or other abnormalities might be susceptible to specific therapies, such as NTRK and so on. But yes, that's actually a very good question, which I'm going to think about a bit more after.
It's an interesting concept, because I think increasingly we're classifying tumors. I've just been thinking about the new myeloid malignancies classification, for example, which is going to rely heavily on these markers. But I'm concerned because of the lack of specificity of some of them, which is the old immunocytochemistry story all over again. But no, it's really interesting. Thank you for that. I'm sitting looking at a screen which has no open questions on it. So I would just urge the participants here that this is our opportunity to ask experts what they think and how best to use the guidelines. So please, can you deliver us some questions? Otherwise, you're just going to get a set of me asking questions, which will not be the most entertaining thing going forward, I suspect. So again, while you're actually going to write something this time, I will ask another question, which is, it's basically comes from the point of view of somebody like me who is who serendipitously comes across spindle cell neoplasms in other practice. And one of the things that's always a question is, before we pass it on to our colleagues who are going to report it finally, is there anything that we should be doing? What is a good panel that we should be going for? Should we be going in with immunocytochemistry? Surely would be the way we would usually do it. Where, just as a subsidiary question coming on from that, will we stop doing that and go straight to the molecular? So what's a good panel for us, and why would you use that? And the second question from that, where does the molecular investigation come in? Do we use that first line, or should we reserve that for second?
That's a very good question. Again, I can actually show you, if you like, a slide of antibody panels that we
That'd
use.
be very helpful. Thank you.
In a second, I'll just answer the second part. When do you do molecular? Sometimes you need to go straight to molecular because of the therapeutic implication, like GI stromal tumor or something else, where the presence or absence of a mutation or a fusion or translocation can be therapeutic. Not many, but it's an increasing number these days. And so you would automatically do the molecular. And often you need it also for diagnosis. Small round cell tumors, it's mandatory because there are so many potential options. But we always do immunohistochemistry as well, because that will give you a first line take on what the tumor is. And panels have been designed. So I divide my soft tissue tumors, unless it's obvious, unless it's fatty or whatever, I divide them into groups on morphology: spindle cell, small round cell, epithelioid, and pleomorphic. And each of those has a potential panel from which we select. Obviously, depending on the case, we can't do them all. Sometimes we do, and the lab just fights back. But you have to do what you have to do. Now, many of these are only available in specialist centers, and of course, how much should should we say the general pathologist, how far can go? Well, a basic panel is often very useful, particularly also to exclude mimics, lymphomas, carcinomas. I mean, if you have a lot of keratin, it might be a carcinoma, it might not be, but at least you then know what the next step should be. And similarly, if it's diffusely CD45 positive, you hand it over to our lymphoma colleagues with relief. But maybe if I can just switch over and show you, I'm not sure if I can, oh yes. I'll show you the sort of panels that we suggest. Let me just.
While Cyril's doing that, have you any comments, Khin, that you'd like to share with us about this issue?
Yeah, I would agree, Peter, in that immuno is really important. Cyril will show our very basic panel that we use, because it can uncover a lot of things. And I think it's important to try and, morphology and immuno, we always rely on that first, because if we end up needing molecular, at least we can target the molecular according to the immunophenotype of the tumor.
So here's a sort of suggested panels for each of the main morphological groups. These are tumors where the differentiation is not obvious morphologically. You know, if it's a fatty tumor, you're in another direction, and so on and so forth. Or if it's, you know, if it's got cross striations, for example, which one hardly ever sees or indeed looks for these days. But these are the suggested panels for spindle cell tumors, epithelioid tumors, small round cell, and pleomorphic. Now, of course, we don't use all of these for every case. We are likely to select. And of course, increasingly, there are new antibodies coming online that we may add to the panels. And so it becomes really difficult. But there are some that you have to do. So a small round cell tumor, you have to do the desmin, the myogenic for a rhabdo, you have to look for Ewings and so forth and so on. You do S100 protein, SOX10 positive, you go towards melanoma. So these are the panels, you know, CD45 and the pleomorphic even, we tend not to dismiss as just pleomorphic sarcomas. We do investigate and look for them, and we will go on perhaps, since there's a bit of CDK4, MDM2, we'll go on to look for that, are they, whatever they may be, and so forth, for dedifferentiated or poor differentiated liposarcomas and so on. So these are the panels we use, and we add the new ones as they come online. So HCK27 is lost in MPNST versus benign nerve sheath tumor. So it can be useful for benign malignant. But generally speaking, the spindle cell tumors, epithelial, these are the basic panels we use. And this will give you the picture. Do you go on to molecular? Well, if you have an answer, if I have an answer for an epithelioid neoplasm, if it's epithelioid sarcoma, i.e. it has CD34, loss of iron I1 and keratin and EMA expression, I don't need molecular because there's nothing to help me there. You may show loss of chromosome 22q, but that doesn't really add. You know that already because you've lost your iron I1 and so on. So that can take you as far as you need to go. With small round cell tumors, molecular is mandatory because the pediatricians require it and so on, pediatric oncologists. And spindle cell tumors is becoming more and more complicated because molecular subtypes are emerging with single gene mutations or with fusions, clinical significance as yet unknown, often small numbers of cases in small series, but information is gathering and we're obliged. A typical example is a CD34 positive spindle cell tumor. There might be lots of things, DFSP, fibrosarcomatous DFSP, or NTRK rearranged, or all sorts of things. And so that would nearly always go off for NGS, to see, unless it were obvious. You know, unless it had muscle markers, something else. So you have to really, or unless it had STAT6, which takes you straight into solitary 5. So you have to tailor a little bit towards individual circumstances. But that's the sort of approach I take.
Okay, thank you very much. That's very helpful. We have a couple of questions that have come in, which I'd like to put to you now. The first one is it's partly related to this topic, but it's focusing on small needle cores and with high-grade lesions. It's just how far do we go trying to investigate needle cores with all the molecular technology that we have available? What's the balance in that going forward? I think that's the essence of that question.
Well, that's another very good question. If there's plenty of tumor in the cores and it looks representative, and generally speaking, fortunately, most sarcomas go in one direction. Some don't, but most do. And if it looks like the same tumors in all the cores, then we can do everything on the cores. We'll do all the immuno on one core, ideally, and then the other core is available for molecular, with whatever the indications for molecular are. They apply the same regardless of the size of the specimen. So we can actually go, if you like, all the way with adequate cores, with the caveat that I mentioned in the presentation, that we divide them into different cassettes. We don't routinely freeze a core, because that will come later if there's a resection, and you lose the tissue in the core. Obviously, you want to maximize it for diagnosis, because it comes up as it were as a virgin. You haven't got a diagnosis. So I think the answer is we do everything we can on the cores. We're very used to doing molecular on the core, and the indications are the same as if it were a large specimen, i.e. you don't know what it is, you want to confirm a diagnosis, or you need molecular data for therapeutic guidance.
Great, thank you. We have another question in, which is, again, it's sort of relates back to what I was talking about before around about the benign malignant diagnosis. So this is specifically asking about how we address the issue of a differential diagnosis between a low-grade sarcoma, spindly thing, together with something like a nodular fasciitis or an ischemic fasciitis, that sort of diagnosis. What are those for many of us are the, when you've got something that's obviously a sarcoma or obviously wildly malignant, there's a sort of relax, we can look at that and say this is malignant, that's fine. But it's these interface ones that are where we get an awful lot of issues around. And how do you recommend we go about that?
Well, you put your finger on the nub of the problem, because this is the hardest thing for us too, who see a lot of these, and major centers may see 2,000 or 3,000 cases a year, but some things don't get much easier. Now, that particular issue of sarcoma versus fasciitis is not uncommon, and morphologically, it's basically morphological. In other words, fasciitis has a variety of patterns. They're clearly myofibroblastic. There's no atypia, there's no necrosis, generally speaking. But if you're still not sure, we now do have molecular underpinnings. For example, fasciitis has a USP6 rearrangement, which often with an MYH9 partner, but now with lots and lots of partners, which is diagnostic, but is not actually present in all cases. It's about 75%, and it's mostly present in the earlier examples. So that can be extremely useful because it's coupled with the morphology, and all molecular information must be taken in conjunction with the morphology. Can be quite diagnostic compared with other spindle cell tumors which do not have that. Having said that, if it's negative for the translocation, and all myofibroblastic tumors, benign and malignant, have SMA only, basically, so that doesn't help you, you have to fall back on morphology. And morphology, obviously, is pattern, mitoses, including abnormal forms, necrosis. And it is a synthesis of those features. And, one has to say, this is where kind of experience comes in, and you send it to the local specialist center. But that is benign malignant really comes down to the eyes, ultimately.
Just if I can ask, Khin, out of the response you just made, you mentioned a number of molecular investigations there. Khin, how do we ask for those? Do we, what is the usual way of asking? Are we looking for PCR, or are we going for next generation sequencing or FISH? What would be the best way forward for these sorts of investigations?
Thanks, Peter. So for many years, we were using a combination, weren't we, Cyril, of FISH and RT-PCR. And now many of us are lucky enough to have access to NGS sequencing facilities via the relevant hubs geographically. I think we have to be pragmatic about how we do everything. Just to also remember that NGS, we kind of think it's the be all and end all. And there are times, for example, when Cyril was mentioning nodular fasciitis, that doesn't pick everything up. So we've had quite a few nodular fasciitis cases where the NGS hasn't picked up the USP6. So I am still an advocate of using what there is and what's pragmatic. I still really like FISH USP6 if you have it, because it tends to be the most sensitive. We have to remember that for certain gene fusions such as CIC, any molecular method is very low, the pickup rate is very low. So for chick rearranged tumors, whether you're using RT-PCR, FISH or NGS, the pickup rate is low. So we always have to go back to morphology. It's a shame that RT-PCR is being phased out in a lot of ways, because we found it very useful. That with a combination of of fish, for example, EWSR1. Cyril, any thoughts on that?
No, I entirely agree, and that's very well put. Yeah, I should have emphasized the use of fish actually for fasciitis because it's relatively quick and precise in this situation. So yes, you made the points. Of course, techniques go as new techniques come in, and it's a great shame. I mean, where's electron microscopy now, which I cut my teeth on for many years and still has a role in my opinion, but you know, whatever works best and is most specific. Interestingly, as I mentioned earlier, you know, NGS and discovery fusions in a tumor is becoming a little bit less specific than it was. And we're going to have to go to the next level of molecular analysis, I think, for more precise categorization and prognostication. But I found, and I'm sure you have, Khin, we're increasingly sending stuff for NGS straight away just to see what, you know, where we're going with this. And as particularly spindle, I mean, small round cell tumors, we've always had to have molecular analysis. Spindle cell tumors is becoming more and more complex because the morphology and immunohistochemistry doesn't really take you far enough. And they've all got different underlying mechanisms or abnormalities. And so almost always now, or certainly in a higher percentage than previously, even a year ago, we're sending it for molecular analysis. And unfortunately, it takes time. It takes at least a couple of weeks. You know, they're high volume, they're batched up, they're not standalone sarcoma, if only we had our own departments and so forth. But it's essential information. And the problem here is getting this through to clinicians who want an answer. So what do we do? We can, sorry.
So it's an interesting point you bring up about clinical expectations, in that my own experience is that whatever the molecular says, they'll believe that despite what the morphology or the ICC might show. And it's about how we handle that interaction with our therapeutic colleagues who are keen to pour pharmacology at folk. But it's the faith that people have in what is, to our eyes, helpful, but not necessarily definitive, and the important piece of putting it all together to make a proper diagnosis. There's a question which arises out of some of this, which I think is probably going to be our last one, but you talked, Cyril, about the differentiation score, and we've also got a question around about the grading of sarcomas on tissue cores and on core biopsies. And for me, there's a lot of complexity about that differentiation score, and I'm not exactly sure that I picked up properly how you apply the differentiation score as opposed to a grading score and how accurate they are on a small biopsy. I wonder if you could clarify that for us, please.
Yes, that's a very good point. The French cancer centers people who designed the system, really Professor Coindre, always say you should not grade on a core biopsy. It's too small, might not be representative, the amount of necrosis is not representative, and so on. However, we are asked to by the clinicians, what is the grade? Because that tends to determine their next step, as far as I can see. So we do grade, but with limitations. So the limitations are, it might not be represented, blah, blah. But the differentiation score is, in a way, the hardest, because you've only got a small amount of tissue. So you have to say, you apply it according to the table, you do the mitotic index, assuming there are enough fields to count, which there often aren't, but you then have to express it as a lower number. You assess the amount of necrosis. And I say, based on these parameters, this is grade 2 at least, because it can only be worse on the resection. It can't be better. So it appears to be grade 1, or it's grade 2 at least, or it's clearly grade 3 with pleomorphism, high mitotic index, and necrosis. Generally speaking, they're grade 2 at least. So there's a caveat that we regrade on the excision, and it may be a higher grade. Can't be a lower grade, but grades 2 and 3 tend to be treated the same way. So it's slightly less intimidating from our point. You don't have to wake up at night thinking, will they take the arm off? That's their decision.
Yeah, thank you. Khin, have you got any final comments to make?
Nothing in particular, Peter. I think Cyril encapsulated that. I think we're all used to our caveats, all of us as pathologists, aren't we? You know,
Yeah.
great through this material, or, you know, our little caveats.
Yes, it's the other thing about it, I guess, is that as far as the molecular investigation is concerned, I still think there is an important role for cellular pathologists in sending the right piece of tissue, because if you send a bit of fat to get molecular testing on it, it won't produce the desired results. And so the only people who can make that differentiation is ourselves, and so an important role for us, whatever. Well, I think as time is beginning to run out, it's probably time for me to say that we should wind this up, I'm afraid. This has been a really interesting session, and thank you both very much for this. We'd just like to remind participants that we are planning having this recording, which this seminar has been recorded, and it will appear in due course as a resource on the college website, to which you will have access as fellows and members. So thank you very much for that. So if you've not watched, or if you've got colleagues who might like to watch in future, you can point them in our direction going forward. So as I said, in terms of time, we do have to stick to time with these things because people are busy. And despite the fact we could continue this conversation for some time, thank you very much indeed, Cyril and Khin, for your contribution, and also for the time and care taken in developing this edition of the dataset. These things take an awful lot of time and effort. One of the things that we will try and do is to log your comments. And if you continue to have comments going forward, please send them to us, because all of those things are useful as feedback for implementation, which help us with constructing the next set of guidelines. These are episodes, not final events, and so it's an iterative process going forward. So please continue to continue the discourse, and we can send any comments on to the expert panel going forward. So all I can say then is to thank you all very much for your participation, thank the panel for participating, but also you'll see on the screen Maria and then some initials. These are Cynthia and Gamze. And the work behind all of this production comes to these three, who have done a huge amount of work to facilitate, produce, and make sure that today's event happened. So thank you all very much for that. And so with that, thank you for attending, and we look forward to welcoming you to the next of the college webinar series. Thank you very much, and have a good day.